Good afternoon, and it's my pleasure to have an opportunity to participate in this program, and I thank Dr. Canna and all of the organizers for the opportunity to do so. This part of the program, I think, is very important because it's going to provide for you an insight into two devices which are coming down the pike for use, which will, I think, solve some of the problems that were discussed earlier this afternoon, which are the shortcomings in some of the devices we use for treating aortic aneurysm disease. The data I'm going to present to you this afternoon on this has to do with the NELIX system, and I'm speaking on behalf of the international investigators. We have a disclosure statement which we put. The ideal EVAR device for treatment of abdominal aortic aneurysm should have a low delivery profile. It should be easy and quick to use. It should have a low incidence of complications, primarily endoleak and migration, and it should have reduced requirements for surveillance. And as you know, the secondary interventions after EVAR are a major problem. And if you look at both these randomized controlled trials and the case-controlled studies, what you see is that there is about an 18% aggregate complication rate for secondary procedures in any one of the groups that you want to look at. And if you look at the abstract of Dr. Manish Mehta and Clem Darling's work from Albany, you'll note that there's about a 40% incidence of type 2 endoleak, 16 of type 1 and 3, and 13 of migration as percentages of the 19% overall need for secondary interventions. And it's also important, I think, for you to note that if you have an endoleak, a type 2 endoleak, which are not uncommon, the cost of surveillance is about 5 times what it is if no endoleak is present. And if you have to do an intervention, the cost is 10 times what it would be if there were no endoleak present. The NELIX endovascular system is really an outside, it's been referred to as disruptive technology. It is really an outside-the-box solution to the problems related to EVAR. And if I can move through this and show it very briefly, this is really endografting for dummies. And all the things that we saw today about having trouble getting the wire into the contralateral limb gate, having to access the arm to come down, a variety of things, pretty much obviated by this device. If you can get a wire from the groin to the suprarenal aorta from both sides and can pass about a 15 French or 14 French system over that wire, you can manage almost any aneurysm combination that there is in the infrarenal abdominal aortic iliac vessels. The NELIX system are 2 balloon expandable cobalt chromium stents surrounded by endobags that are filled with a polymer. And we'll show you what that's about in just a minute. The NELIX system started in its development in 2004. The concept was developed. They went in and formulated the endobag, which is where the polymer is contained, and this is the cobalt chromium stent. And what you see is the final, this is the 3rd iteration of the delivery device system, and it is now pretty much all automatic. It's connected to a console. This is the polymer as it's delivered. It's connected to a delivery system. And all the operator does once he gets the wires up is basically press some buttons and make sure that things get done properly. It is really a, let me see if I can make this work for me. Okay. This is the delivery system. It encompasses a angio port through the end, so you don't have to have a pigtail catheter or anything similar to it to do your angios as you're progressing through this. And it's pretty ergonomic in the way it works. And these are the devices that connect to the console, which monitor the pressures as you insert it. And this is the polymer delivery system, which connects to it. And it's pressure monitored, and the polymer is placed into the bag, into the surrounding endobags around the graft at approximately 180 millimeters mercury pressure. And what you'll see, and this is Andrew Holden deploying one of these devices, you'll see them going up. It's basically delivering 2 separate systems from the groin. Once they're in, they're unsheathed as he is doing now. And then you do your angio through the tip of the device, or you can have a pigtail, either one, and confirm where your renals are, make sure that all the device is properly positioned above the hypogastric arteries and below the renal vessels. And once you have it in place, then you begin to deploy the balloon expandable cobalt chromium stents. That's what he is doing now. You'll see they'll start to inflate. They're either 8 or 10 millimeter in diameter lumens, depending on the size. Let me move forward through this. And as you can see, as the device begins to fill, the polymer is filling in the endobag, which fills up the entire space inside the aneurysm sac. And as this polymer begins to cure, the aneurysm loses its pulsation, and you can put your hand on the abdomen and feel this as it stops right while it's going on. It takes about 3 minutes, maximum 5 minutes for the polymer to cure. And this is what holds the device in place. I mean, there is really no migration with this device, and as you can see, there's no place for endoleaks because the polymer-filled bag closes off all the branch vessels, and so there is no place for the endoleak to go. Once here's Dr. Holden filling the polymer bag with the material. It has a pressure monitor on it. I won't dwell on this. And again, here it is. It's fully, the polymer-filled sacs are fully deployed. As you can see, they're not radio opaque, but they do have a little, under fluoro, you can see them somewhat easily. And then finally, you just remove the delivery system from each side, and you're done. And here is this is the Nelix system, pre-contrast to post-contrast. And again, you can see how the flows are. This is a surveillance with ultrasound post-operatively. The Nelix system is designed to address challenging proximal necks, treat iliac aneurysm disease. It has a low-profile delivery system, one of the lowest out there. It reduces the rates for reintervention. It reduces the surveillance requirements because the device really can't go anywhere. Once this endobag is filled with the polymer, when it's cured, has a consistency of jello, hard jello, or they describe it as a pencil eraser. And that is what really lends the entire support and fixation system to this device. So addressing the challenge, the necks, certainly they can treat necks of almost any length, but their IFU will probably be somewhere around 5 millimeters in length. Irregular necks, reverse cones, anything of that nature will be easily managed. And this will give you an idea of the short proximal necks, where this is with a large posterior bulge right below the renal vessels, which I know you've run across in your practice if you do much of this. And as you can see, it can be treated very easily with this endobag system. There it is, the endobag is filling that bulge below the renal vessels, and the entire process is well stabilized by it. There's the pre-procedural CT, post-procedural CT, again, and the stability of the two limbs within the endobags. 5 millimeter neck, here we are again, very short neck below the renal vessels, and very easily stabilized with this device. And this is a reverse cone, again, the same kind of stabilization system. Treats iliac aneurysm disease. The iliac aneurysms treated can be up to almost any size. They treated 35 millimeter iliac aneurysms in some of their trial cases. And these are just a few of the types of aneurysms that they've managed. Again, more of the same. Here's more iliac aneurysms managed because the endobag also goes down into the iliac vessel and stabilizes it there so that you can actually anchor your device within the aneurysmal iliac artery and maintain blood flow to both the hypogastric and the external iliac vessel. It's a low-profile system. It reduces the needs for reintervention, and certainly the need for surveillance can pretty much be reduced to ultrasound surveillance only rather than serial CT scans, because what you're looking for, the things that we look for with CT scans, obviously surveillance of type 2 endoleaks, are really no longer an issue. So it reduces the procedural and follow-up costs substantially. It does prevent type 2 endoleaks because the endobag fills, and here's just an example of it. Again, multiple lumbar branch vessels going into the sac, and as you can see, they're not present once the endobag is deployed. Again, similar view, similar problem, a patent IMA artery, one of the major causes for type 2 endoleak, and you can see here the collaterals are present, but the leak is no longer, the branch vessel is no longer patent. Again, lumbar vessels in an IMA, see they're sealed because the endobag closes their point of entry into the aneurysm sac and minimizes the need for. So the global experience with NELIX thus far, 47 patients. The follow-up CTs were at 30 days, 6 months, and annually. They'll be up to 5 years. They're submitted to Core Lab study and independent evaluators of the, this is just a follow-up showing you the number of patients that are out, the number of years. We have 2 out 3 years, 23 out 2 years, 32 out 1 year. And the demographics are pretty much what you would expect for someone with aneurysm disease. It is important to see that the neck length and neck diameters are somewhat interesting. Those with short necks there were 10% of them, and there were 34% that had large common iliac artery aneurysms. The procedural time, relatively short, and if you'll note, the time in the hospital was plus or minus 3 days, but remember, most of these are done in countries where the standard for doing this is under general anesthesia rather than local anesthesia. In our institution, our endographs come in one day, go home the next, and they're done under local anesthesia. Here's the meat of the talk, which shows what happens with the endoleak. There was one type 1A, one type 1B, and one type 2. There were no ruptures, there were no conversions, there were no device migrations during the follow-up. And the type 1A endoleak, which was present, was really, this is an endoleak by definition, not by significance. There was a severely angulated neck, and there was some filling of the contrast right in the very proximal area where the endobag was just below the renal vessels. And you can see it was a cul-de-sac type arrangement, which at 1 year was totally thrombosed and has remained that way over 3 years of follow-up. This is the type 1A again, as you can see. There's been no change and no recurrence of it after it closed or finished, sealed at that first follow-up visit. The 1B was a device deficiency, and that was early on. They did not have endobags that completely filled the iliac arteries, and therefore there was a branch vessel coming into this area that produced a 1B endoleak at the distal attachment site, and that had to be fixed with a commercially available limb at 15 months. There is noted no reports of rupture, conversion, or device migration, very limited endoleaks in those. The one type 2 that was present was because the endobag itself was too small to fill the entire cavity of the aneurysm, and this is a situation that's really a device choice size related. There was one early death from multisystem organ failure in a very poor risk patient. This was not device related. The 2 late deaths were related to congestive heart failure and cancer, totally unrelated to the device. So this NELIX system treats most infrarenal abdominal aortic anatomies. It's very low profile, easy to deliver. If you can get the wire from the groin to the renal vessels, you've got the case done. It has a low incidence of complications, it essentially eliminates endoleaks and migrations, and reduces the requirement for surveillance. The future is here with respect to the management of infrarenal abdominal aortic aneurysm disease with this device. It is right now scheduled to commence FDA IDE trials in the United States during the third quarter of this fiscal year, probably in October, and it is going for CE mark in Europe very soon. Very, really outside-the-box thinking, and in my judgment, the kind of investigation and thought process that should be applied to a lot of other things in medicine. Thank you.
Thank you. Thank you, Clifford, to report this fascinating technique. Can you tell us more about the composition of this polymer? And did you notice any allergenic reaction or something?
The polymer is a polyethylene diacrylate and polyethylene glycol diacrylate. And it forms a substance as it cures. It is a very low viscosity when it goes in like water, easy to put in. Once it cures, it gets a consistency of, I think firm jello would be a very good idea, a very good description. So people have asked what happens when the thrombus, which is inside the aneurysm sac, begins to resorb. Is there a space that forms between the endobag and the aneurysm wall? The answer to that is no, because the endobag is pressurized around 170, 180 millimeters of mercury by that system that delivers it. And so as thrombus resorbs from the aneurysm wall, the bag actually expands to take up the space. And so there really is no space for an endoleak to occur in late follow-up.
So you have to come back next year to report a longer follow-up.
Yeah.
I'll be happy to do that.
Thank you.
Yeah, thank